gentlemen. Can you all hear me? Good evening, ladies and gentlemen. Can you all hear me?
Yeah, we can hear you.
Yes, good. So, good evening, ladies and gentlemen. I welcome you all for this new series of lectures organized by UVA Clinical Society on COVID pneumonia. The main aim is to update the knowledge on management of COVID pneumonia among doctors. As you all aware, we are now almost into the third year of this pandemic, but the symptomatology is still changing and the management is still evolving. So it is very much important to update our knowledge on current trends in managing patients with COVID pneumonia for better patient outcome. Without taking much time, I will move on to the topic lecture. Today the topic is management of COVID pneumonia, evidence-based approach. The speaker is Dr. Hirantha Pathirathne, the consultant case physician, respiratory physician, Provincial General Hospital-Badulla. Dr. Hirantha is involving extensively in managing complicated patients with COVID pneumonia during past 1 to 2 years. So he has a very good experience in managing these patients. So before I hand over to Dr. Hirantha, if you have any questions, you can ask at the end of the presentation, or you can type in. So I hope we all can learn from this lecture. Over to you, Hirantha.
Yeah, thank you, brother. Good evening. Hope all can hear me well.
Yes, Hirantha, we can hear you.
Yeah. Good evening. And Gihan, can I start sharing the screen? Yeah, hope you all can see the screen now.
Yes, we can see the screen here.
Yeah, okay. Yes. Okay. Yes, good evening. And first and foremost, I should be thanking UCS for organizing this series of timely lectures and making me a part of it. Just to begin our discussion, now we are facing a new pandemic with immense amount of new problems. And with regards to the disease, we are having lots and lots of information. And not only regarding the disease, but also with regards to every aspect of our lives. And our lives have been changed or being changed. So be it social, be it political, or be it economical, and now we are adapting to a new normal life. So the scope of today's lecture is Rather, it centers on evidence-based practice, so evidence-based management of COVID pneumonia. As you can see on the slide, evidence-based practice means not only the research evidence we got, but incorporating that into clinical experience as well as patient preferences as well. Along with the viral pandemic, we are experiencing an information pandemic as well. So there are lots of research and publications widely available for access. And I mean, one gets lost in this information pandemic as to choose between contrasting evidence. So therefore, it is important to obtain information from a trusted and reliable source. So for evidence, as evidence for today's topic is basically gathered from two reputed sources. Those are the European Respiratory Society Living Guidelines and the National Institute of Health COVID treatment guidelines, which are constantly being updated in the web. And anybody can access these guidelines with reference to evidence as well, by which they differ from other guidelines where you don't get the references for the evidence rather. Today's lecture is rather centers on patients who are hospitalized following COVID. And I don't think I'm having time to discuss about home-based management or patients who are not hospitalized. All right. So a brief word regarding the pathophysiology of COVID-19. As you all are aware, the virus gains access to the body through the respiratory or the nasal epithelium, where the virus gets attached to the nasal epithelial cells through the spike protein with the help of the angiotensin converting enzyme receptor. Then the virus is taken into the cell and it replicates there, and the viral copies are rather expelled both into the environment and into the lower respiratory tract as well. And basically in the lower respiratory tract, the virus attacks the type 2 pneumocytes and causes destruction and a massive amount of cytokine release, which rather results in a storm of inflammation rather, and local cellular destruction, giving rise to various complications of the disease. So this bit of information is rather important with regards to certain management aspects. We'll discuss it later. So the management of COVID pneumonia rather involves in 4 basic steps. Rather, we have to stabilize the patient initially. We have to identify the disease severity, the disease stages, and we have to consider some special information with regards to high-risk groups. So we rather discuss one by one. And the initial stabilization is rather universal to any patient. And it starts at the earliest confrontation with the patient. In our setting, it's not done at, it should not be rather done at 24A or B or C wards. It should be done at the initial patient encounter, wherever in the hospital. So this is rather basically universal for any patient with pneumonia management, or any patient with sepsis. We rather have this ABCD approach. We look into the airway, oxygenation, breathing, ventilation, circulation, shock. and we do the initial resuscitation if necessary. All right. And in the initial assessment, it's very important to get a brief history with regards to the onset of the symptoms. It's rather than the date of PCR becoming positivity, the day the patient felt his first symptom is rather important in identifying the stages of the disease and subsequently initiating the necessary management steps. So, as you all are aware of the symptoms, basically patients can have initial headache followed by a fever, stuffiness in the nose, loss of smell, loss of taste sensations, followed by a dry cough. And basically, this is rather common to any viral illness. So the initial assessment involves a brief examination as well, specifically looking at the respiratory rate, oxygen saturation at rest, and if possible, exercise desaturation. And we can auscultate the chest. Yeah. So the disease is graded according to the severity as mild, moderate, and severe. Of course, with the upper respiratory tract symptoms, maybe an associated diarrhea and myalgia, patient is regarded as having mild symptoms. And if the patient is on supplemental oxygen and the respiratory rate is not more than 30, it can be regarded as a moderate disease. And anything beyond that, the patient needing high flow oxygen and the work of breathing is more, it can be regarded as a severe disease. So how do you stage the disease? I think I have shared this with you all in a previous lecture as well. So basically, the COVID-19 disease has two phases. First is the viremic response, and the next is the host inflammatory response, and there's a considerable overlap in between. Stage 1 involves the early viremic phase, where the patient has initial symptoms, and it can last for up to 5 to 7 days. And stage 2A, this is rather academical, is where the patient is not hypoxic, but the patient has evidence of radiological infiltrates on chest X-ray. And stage 2B is where the patient is becoming hypoxic, as well as the chest X-rays are showing infiltrates. And stage 3 is rather the critical phase or the hyperinflammatory phase, where the patient's oxygen demand increases and the features of ARDS, shock, and cardiac failure appears. And along with this timeline, as you can see, the biochemical markers as well as the hematological markers are changing as well. Basically, the D-dimers, the LDH levels rises, and there's a transient transaminitis as well. We'll talk about them later. So this is rather a clinical depiction of the previous slide, where with time, usually the course of the illness is from day 0 to day 40. And as you can see, the viremic response wanes off in about 10 to 14 days. And from day, we say 4, 6 onwards, as the inflammatory process takes place, the patient gets admitted to the hospital and the patient experiences shortness of breath, and gradually the patient deteriorates, needing ICU care. Right, and a few words about high-risk groups. As you know, the elderly patients, patients with significant comorbidities, patients on immunosuppressive drugs, transplant recipients and pregnant patients should be looked after rather carefully, or rather assessed carefully. So we'll straight away jump into the management of the disease. So in the initial viremic phase, what are the management options do we have? It's rather now, as I'm limiting this talk to hospitalized patients. In the early viremic phase, the patients do not require oxygen. So we'll see as to what happens or what are the evidence for drugs during the initial viremic phase. Obviously, the guidelines recommend that we should not be using steroids at all. So from where this evidence is coming, it is coming from this major trial named Recovery Trial, which took place in UK, involving around 6,000 patients. And in that trial, in the dexamethasone arm, they haven't seen any survival benefit by using dexamethasone on hospitalized patients who are not on oxygen. Rather, they have seen more deaths associated with that. So both guidelines mention that we should not be using steroids at all in the initial viremic phase. And what about antivirals, remdesivir? There's no clear benefit according to these two trials, the ACCT and the Solidarity trials. But there's a conditional recommendation that we can use remdesivir in patients who we think that there's a high risk for deterioration, as it may be a patient who is falling onto the above four categories I mentioned before. Right. So in the early viremic phase, we don't have any approved drugs. And there are these monoclonal antibodies which can be used as for emergency use, but we don't have them in Sri Lanka. Remdesivir, of course, now it is available in certain centers. They have used it in a few patients rather. So this may be used, but I'd rather doubt with its in our setting. There's a strong no for steroids and antithrombotics. Yes, I will discuss that later. Then the vitamin supplements, vitamin C, D, zinc. Again, there's no clear evidence with those. We'll talk about them in detail later on. And this wonder drug azithromycin. So we'll talk about it in few minutes as well. So in the initial phase of the management, now in our setting, we rather tend to use this cocktail of medications. Everybody becoming positive for COVID are rather prescribed with this COVID pack, which contains these. So according to the evidence, prescribing steroids in the early viremic phase is rather harmful. Right. So in the next step of management, it's stage 2A, which I have mentioned already as rather academical. It's basically the same as in stage 1, where we can use remdesivir if needed, and these drugs if needed. And we move on to stage 2B, and by that time the host inflammatory response has begun. So the patient is becoming hypoxic. So what are the drugs we can use? Again, there's strong evidence for dexamethasone coming from the recovery trial, and it has shown survival benefit. Or we can use this dexamethasone remdesivir combination, which has a theoretical benefit, adding antiviral to dexamethasone. And In contrast, remdesivir monotherapy is not recommended. So what else we can use in stage 2? Apart from dexamethasone, we can add these NIBs or MABs. Baricitinib is not available in our country. These two trials, the core barrier and ACTT2 trials, have mentioned that there's reduction in all-cause mortality and improved time to recovery with the use of baricitinib. Of course, we do have tocilizumab, which is interleukin-6 inhibitor, and where we can get the evidence is from this REMAP-CAP trial, which involved many ICU patients in UK, and it has shown that there's a reduction in hospital mortality and increased days of free of respiratory or cardiovascular organ support. And it has been shown that tocilizumab is more beneficial in patients with rapid respiratory decompensation. So in this phase, we should be rather carefully monitoring the patients, and we should be rather identifying the correct phase we should be starting tocilizumab. And the recovery trial also has shown some reduction in all-cause mortality with addition of dexamethasone to tocilizumab. So this step we are practicing in our setting, and it rather depends on the availability of tocilizumab. So when tocilizumab is not available, we have this, we can use sarilumab, again not available in our country. But this newer drug, tofacitinib, is rather available. It's a JK inhibitor, it means Janus kinase inhibitor. And it should be used in conjunction with dexamethasone. So where are we getting the information is from this Stop COVID trial, which has shown that there's a reduction in respiratory failure and death and all-cause mortality. Yeah, then we have, so we discussed regarding patients who are not on oxygen, patients who are on supplementary oxygen, and patients who are on high flow oxygen. And patients on mechanical ventilation, the evidence is for dexamethasone alone or dexamethasone plus tocilizumab. And again, the evidence is coming from recovery and REMAP-CAP trials. Yeah. So in a clinical perspective, along with pharmacological management, we are rather stepping up on oxygen requirement. And once the oxygen requirement is going up, we should be rather carefully assess the cause for deterioration. It could be something secondary, like a hospital-acquired chest infection shown in the first picture, or a pneumomediastinum or a pneumopericardium in the second picture. And sorry, the next picture is missing. It's a pneumothorax rather. So it's rather a good practice to perform a chest X-ray whenever the patient is deteriorating at each and every step, or at each and every step we are increasing the oxygen levels, just to assess for a secondary cause for deterioration, other than changing the pharmacological management. Yeah, it's the pneumothorax. Yeah, so in stage 3, we are stepping up of oxygen, and we have to rule out bacterial sepsis, in which the procalcitonin levels become handy. And generally, the IL-6 inhibitors are recommended once a bacterial sepsis is ruled out. Then there's a place for tofacitinib, and then we have to have an NDT discussion regarding the next steps of management, intubation. So in a nutshell, this is what we practice almost all patients coming into the hospital should be given antithrombotic treatment, even though they are not requiring oxygen. We'll discuss it again. And if the patients are on supplemental oxygen, we have these pharmacological therapies, steroids and interleukin-6 inhibitors and tofacitinib. And patients requiring NIV support, we rather, there's strong evidence for high flow nasal cannula and CPAP. Right. So this is again, just to summarize what we do. And one important thing to remember is that at each and every step, the patient can exit this deleterious curves. That means patient can come out of the disease at stage 1 or stage 2A, 2B, or at stage 3 even. So it is important to escalate the treatment rather in a stepwise manner. That means that we should not be initiating rather high flow oxygen at stage 2A or 2B, where which would be a waste of resources, as well as which would be having some adverse reactions later in the clinical course. Right. So we'll discuss with regards to each and every drug separately now. With regards to vitamin C, now as you all know, each and every patient with COVID is prescribed with lots and lots of vitamins, especially vitamin C. It is an antioxidant and an anti-inflammatory drug as well. So there are lots of trials done on ICU patients who are critically ill, but the evidence is rather limited. And even in non-critically ill patients, there's insufficient evidence for the use of vitamin C. IV ascorbic acid, I don't think we are using it in Sri Lanka. When we use IV ascorbic acid, it may interfere with the blood glucose monitoring, rather glucometer readings, where it can give erroneously high blood sugar values. And IV ascorbic acids may augment acidosis as well. So what about oral ascorbic acid? Now, if you can follow this graph with administration of 500 milligrams of element ascorbic acids, we have rather reached the plateau plasma ascorbic acid levels by about 75%. But by repeated dosing, this response is rather sustained. But by repeated dosing, we are not achieving much. So it is a good practice that we should rather recommend a daily dose of vitamin C, rather not exceeding the limits. And higher doses of oral ascorbic acids may give rise to GI side effects like nausea, vomiting, and diarrhea. So it may be the reason why we are seeing lots of patients in the wards having some maybe having diarrhea due to COVID illness. Some may be iatrogenic even. So what about vitamin D? It's again an immunomodulator, and again there's insufficient evidence in relation to COVID. Now that many of us or the whole population is rather vitamin D deficient, if we do a trial, we may get positive results, but that doesn't mean that we should be supplementing vitamin D at an excess. And another bad aspect of over supplementing these vitamins would be many patients would be rather consuming the vitamins rather for longer periods. We say some may be consuming them as hoping that the pandemic would come to an end soon. So they will be rather taking the vitamins continuously. So it's should be rather discouraged.
Oh, Mumbai में वो डाल दी
Sorry, we got some disturbances. Right. So again, high doses of vitamin D may cause hypercalcemia and nephrocalcinosis in the long run.
Hello.
So what about zinc? Zinc again is implicated in replication of RNA viruses, where the high doses of intracellular zinc rather inhibits viral replication. But again, there's no trial evidence in COVID, and with long-term use, it can rather potentiate copper deficiency, which may manifest as neurological manifestations. So what about azithromycin, the wonder drug? So azithromycin is a bacteriostatic agent which inhibits bacterial protein synthesis. It is an immunomodulator as well, used in very many conditions, and it exhibits in vitro antiviral properties as well. And in the guidelines, there's only a conditional recommendation for its use in presence of a bacterial infection only. And where this evidence is coming is from these two trials, the Atomic 2 and the Action trials, which have shown that adding azithromycin to the standard care has not reduced the risk of subsequent hospital admissions. So in Action trial also, they have not detected any outcome differences versus a placebo at the end of 2 weeks. So what do we do if we did, what should we be doing if we detect a patient with rising CRPs? As you all have encountered, many of the COVID patients have rising CRPs. And if you rather go through this graph, these are few Chinese studies where they have assessed CRP response in a background of normal procalcitonin levels. And as you can see, from the state of non-severe to severe, there's a gradual rise in CRP with the disease. So, and it is up to, we say about up to 60, they have observed this CRP rise. So within this window period, we can rather play safely without antibiotics, but it is rather a clinical decision to start on antibiotics. Yes, and what about ivermectin? And these days, many people talk about ivermectin. So it's again implicated as an antiviral agent. It inhibits intracellular viral transport, interferes with the spike protein attachment, and it exhibits anti-inflammatory properties. And it inhibits viral replication in cultures as well. But they have noticed that we need rather high doses of azithromycin, sorry, ivermectin, to be used as a viral inhibitor. And in animal models also, subcutaneous administration have not resulted in any satisfactory conclusions. So the evidence we have for ivermectin is rather inconclusive at this point. And what about the chloroquine hydroxychloroquine combination? Both are again immunomodulators, and they have some properties with the ACE2 receptor, so thereby directly interfering with the viral attachment. Again, these two trials, the recovery trial and the PETAL trial, have shown that there's no benefit, but they have noticed that there's an increased likelihood for intubation with these two drugs. And certain trials have been done with hydroxychloroquine plus azithromycin combination. Again, there's no clear benefit. And again, these can rather augment cardiac adverse side effects like prolonged QT interval. So in summary, antiviral agents, so far to date, remdesivir is the only approved antiviral agent. And for ivermectin, we have insufficient evidence. And this nitrous oxide, hydroxychloroquine, HCQ, azithromycin combinations. And for HIV protease inhibitors, there's a strong no. Right. Then there are these antibody products. We don't have monoclonal antibodies in our country, but convalescent plasma had been used in several patients in our country as well, but the results have been rather inconclusive. And in guidelines also, it is rather not recommended. And for anti-SARS specific immunoglobulin, again, there's insufficient evidence. So in summary, these are the medications we have at present to be used in COVID patients, remdesivir, dexamethasone, tofacitinib, tocilizumab. So yeah. And can we use other steroids along with dexamethasone? Of course, dexamethasone is the extensively studied steroids in Western world. Of course, it's long acting and once daily dosing is recommended. But if we can use rather equipotent doses of other steroids as well. If you use prednisolone, it will be 40 milligrams and it can be a once daily or BD dosing. And methylprednisolone, again, the equivalent would be 32 milligrams. And if you use hydrocortisone, it's rather short acting. It's rather given in QDS form. And with regards to inhaled steroids, again, the evidence is rather insufficient, but certain studies are demonstrating that the inhaled steroids can halt the viral replication in the nasal mucosa. Still, we don't have convincing evidence. So what about methylprednisolone pulses, which we use extensively, rather extensively in our setting? Again, these two guidelines doesn't mention about methylprednisolone pulsing. So in certain institutional guidelines, they are practicing giving methylprednisolone pulses as an alternative to tocilizumab. So there are certain studies which have shown that there's a survival and a mortality benefit with intravenous methylprednisolone pulses. And with regards to our experience, well, it's rather a mixed experience, but the sad story is that we don't have any properly collected data to be analyzed. So it would be a rather good exercise if we can rather go back and see whether how the patients have performed with methylprednisolone pulses rather in a statistical manner. Yeah, then about thromboprophylaxis, Vt prophylaxis. The recommendation is that all hospitalized patients with COVID-19 should receive Vt prophylaxis. This all patients include the patients who are on oxygen and who are not receiving oxygen as well. And the evidence is rather straightforward that they have detected more incident, rather high incidence of VTE among COVID hospitalized patients than non-COVID hospitalized patients. And interestingly, these three studies have compared the prophylactic doses versus the therapeutic doses. And what they have noticed is that the need for organ support or the ICU care, needing the requirement of ICU care have not changed with using prophylactic or the therapeutic doses of enoxaparin. And with the therapeutic doses, they have noticed some safety issues as well. Yeah. So, yes. Yeah, that's rather, I mean, I'm coming to the end of my presentation rather. That was rather to look into the current evidence we have with regards to the pharmacological management of COVID-19 patients. I didn't touch on the oxygen therapy because you will be hearing a lecture on critical care aspect of COVID-19 in next week. In my final slide, what I want to emphasize is that at whatever, I'm sure you must be knowing this theory. This is rather, it's rather a common phenomenon in epidemiology, the hammer dance theory, where in the hammer stage, we rather extensively try to control the virus, thereby at whatever the cost, we try to cut down on the number of cases we have so that the people can dance. So the dancing period will rather depend on how tight we apply the brakes. So my pledge to everyone is at whatever encounters, we should be rather limiting the spread of COVID virus so that the number of cases would limit. So by the mortality would go down and the long-term complications, the mutation rates would go down. Thereby, we could rather see rather an end to this COVID pandemic. Yeah, thank you.
Thank you, Hirantha, for that excellent and informative presentation, which is practical as well. So now the lecture is open for discussion. Any questions? If you have any questions, you can ask now. And also, if you can type in, I can convey the question to Dr. Hirantha.
There's one question. Is there any place for antiplatelets? Now the recommendation is if the patients who are already on antiplatelets to continue, but for newer patients, we don't have any evidence in the initial stages to use antiplatelets. But now in pneumonia guidelines for severe pneumonias, considering the considerable cardiovascular mortality at the initial first month, we tend to prescribe antiplatelets. So in severe COVID patients also, during their recovery phase, after stopping enoxaparin, as a clinical practice, we rather prescribe aspirin, but it's not in guidelines rather.
Yes, another question. Any place for use of theophylline and some cough syrups in COVID patients having cough?
Yes, definitely. With any viral pneumonia, you can get a rather induction of a state of wheeze. Viral pneumonias are wheezing inducers rather. So bronchodilators have a place in managing it's rather a asthmatic state. So bronchodilators do have a place.
I think you have mentioned this. What are the indications for IV methylprednisolone sulfur? So you mentioned clearly there are at the moment no evidence for methylprednisolone. Am I right?
Yes, Anurag. There's in there are no clear evidence for methylprednisolone pulses in guidelines, but in certain institutions all over the world, as well as in Sri Lanka as well, clinicians are using methylprednisolone, and as it's quite evident, we also we are also practicing this as an alternative to tocilizumab. And yeah, what are the indications for IV methylprednisolone pulses? It's again the same. As for tocilizumab, when the patient is having increase in oxygen demand and the CRP is rising, and the clinically the patient is having increased work of breathing, that is the critical time frame we tend to administer tocilizumab, and it is again same for methylprednisolone pulses. So the idea behind that is to counteract the cytokine storm. Yeah, the next question, yeah, I can say, why should we do procalcitonin in COVID? Yes, as I have mentioned, now as the disease advances, we have seen that the CRP level is also rising. So we don't know whether the CRP rise is due to a settlement of a secondary infection or to the disease process per se. So to differentiate it from a bacterial sepsis, we rather perform procalcitonin, and it is generally should be performed before administering methylprednisolone or tocilizumab. Yeah, the next question is the same. Yeah,
Who receive anticoagulant? What should be the better anticoagulant, warfarin or not?
Yeah, it's rather a good question. Again, I deliberately didn't speak about this because there's another lecture coming up for with regards to post-COVID management. In our setting, warfarin would be a better choice because it can be monitored. But with Novax, since it can't be monitored, and we don't know exactly about the disease dynamics in the long run, so I rather prefer warfarin over Novax, but rather should be supplemented with trial evidence. Yeah, the places of LDH and D-dimers. Yes, no, the place of LDH, again, similar to CRP, the LDH levels will rise as the disease progresses, especially with the cytokine storm. And D-dimers, yes, the disease per se is thrombogenic, and the D-dimers level will eventually rise, and the levels would rise as the disease advances. Now, if we are suspecting a major thromboembolic disease, then we can rather see the titer of D-dimers or the changing levels. What about use of dexamethasone even with the evidence of secondary bacterial infection? Yes, it's a good question. Well, in a clinical perspective, I would not be stopping steroids in a setting of a secondary bacterial infection. Rather than I would be rather covering that with stronger antibiotics. So in a trial evidence, I don't know whether there's any evidence available for this question.
Question also, Hirantha explained if there is no oxygen requirement and if the patient is in early viremic phase, no need of these treatments. No, if I simplify, no oxygen, no treatment. Am I right, Hirantha?
Yes, it's rather a symptomatic treatment. Whether if the patient is having a cough, we can rather attend to that. If the patient is having a diarrhea, we can rather treat that. But if the patient is not requiring oxygen, then there's no place for steroids. Rather, it is rather harmful to use steroids. And the place of azithromycin, as I mentioned, yes, it's rather a conditional use. If you clinically suspect there's a bacterial sepsis on top, you can use. Otherwise, better not use that. The next question, I'm not clear. What's the place for early in the sense early hospital admission? Am I correct?
That is also not clear. We will see early hospital admission. So
Then again, that is rather it's rather controversial now. Now that the home-based management is implemented, I don't think that it's wise to recommend all the patients should be coming in early without symptoms. Only the symptomatic patients, symptoms of Ascorbic should be rather admitted. How to decide at which point exactly we should start DEXA? Yeah, that's exactly what I have been telling. At the initial point where we see oxygen desaturation, we should be starting the patient on steroids. It could be the exercise desaturation test even.
if I modify that question, is there any target we are aiming that if the saturation is going beyond 94, only we are starting, or if the patient is sort of desaturating from 98 to 95, are we going to start?
Yeah. If the target saturation is not achieved, that is 94, then we have to definitely start. And if there's oxygen desaturation, we say 98 to 95, then we should be starting dexamethasone.
We have to start, no?
Yes.
Okay.
And how to decide at what point exactly we should be starting dexamethasone again, just to add to that, that is where the clinical disease onset is becoming quite handy. If we exactly know at what day the illness began, then roughly we can pinpoint to a certain duration. Roughly it's between day 5 to day 8 that the patient starts desaturating. So it's again useful exercise to have a clear history. What are the current evidences regarding intubation?
Shall we skip that now? Next week we are discussing.
Yes. Heparin nebulization. Of course, this I don't know. Any idea from you on rather heparin nebulization?
I haven't heard of in this COVID. We are not practicing anyway.
Yes.
I don't know where he or she get this information.
Yes, probably you can rather update us even.
Yeah,
that's quite okay. And since there's a place for bronchiolitis, SABA monotherapy recommended. Now, again, a good, very good question, I would say. Now, if we take recent asthma guidelines, it is the formoterol budesonide combination is recommended in step 1 of the disease, rather than short-acting beta-2 agonist, that is salbutamol nebulization. So, if we encounter already diagnosed patient with asthma, having COVID and having symptoms, it's not wise to start a SABA monotherapy. But if the patient has COVID-related symptoms, wheeze or bronchitis, then there's a place for, you can rather try with salbutamol inhaler and see. And if the symptoms are ongoing, it is better to use a combined inhaler, right? Like formoterol budesonide. Clear?
Yes, that is clear, Hirantha. And the next question also you explained, they are asking CRP cutoff for dexamethasone. What I can say is with the antibiotic cover, we can give dexamethasone if we are suspecting secondary infection.
Yes, and I would say that for TOSI, there's no such CRP cutoff rather. We don't go by CRP values to initiate TOSI. It's rather the procalcitonin.
Procalcitonin, yes.
Place of physiotherapy, and shall we continue once the D-dimer level high and suspecting thromboembolic event? This is well, I think we should be applying this sort of a scenario in a case-by-case manner. Whether chest physiotherapy is rather appropriate for a COVID patient in a critical state, that is rather should be addressed in a case-based manner. There's no clear-cut answer to this. If we suspect a major thromboembolic event, we would rather not embark on chest physiotherapies.
And about that previous question about the heparin nebulization,
yes. Unfortunately, we don't have any experience with that. Yes. Yeah, desaturation test negative, then we can rather observe the patient. The next question, patients with SOB, but SpO2 more than 95 and desaturation test negative, then it's a good question that in the initial stabilization of the patient, now most of the COVID patients are rather quite anxious. So in your initial stabilization, we should rather relieve the anxiety as well. Sometimes they rather settle with that. Their complaint of SOB would rather go away. Also starting aspirin for hypertensive patients in early stage. Again, I'm not very sure for this question. I think as for other patients where we start aspirin for certain indications, it should rather apply for COVID patients as well. Doesn't it, Anurag?
The patient we have treated for severe COVID pneumonia. Is there a place for giving aspirin for certain post-COVID period as well, 1 to 3 months, like?
Yes. Yeah, absolutely. That's what I mentioned previously, because there's evidence for antiplatelet therapy in severe bacterial pneumonias following discharge. So similar situation applies to COVID as well. We can rather use, but I'm not very sure whether we have evidence for that. But I'm sure we'll be listening to that talk in a couple of weeks. No harm to use IV magnesium sulfate for acute SOB wheezing COVID patient emergency. Yes, as you treat a patient with acute severe asthma, we can follow the necessary steps. There's no harm to use magnesium sulfate. An ideal time for vaccination after primary infection, it's generally recommended after 1 month post-infection.
Any other questions? Anyone wants to speak, then we can give a chance.
No, Anurag, here.
Oh,
So it's very interesting actually. This is the mainly inward management of the COVID patients. So with regard to antibiotic and all, I think they have got some kind of I don't know whether they are confused with, we are using a lot of third generation cephalosporin and azithromycin. That is actually, when we use it, I always tell them this is not for the virus infection. This is to cover the secondary bacterial infection, which basically you can get with this high dose dexamethasone and all. I really don't know why they have selected this third generation cephalosporin rather than using any other co-amoxiclav or other things to cover the gram-positive things. Is there any idea about that, Hirantha?
Yes, it's like this now. According to the Sri Lankan guidelines of managing community-acquired pneumonia, the recommended antibiotics are coamoxiclav plus a macrolide.
Yes.
So, but as now those guidelines were laid a few years ago. Now, from a clinical perspective, what we have seen is that the coamoxiclav resistance is emerging. Now, if you take the hospital data, that will show that many patients have developed coamoxiclav resistance. So, we were rather inclined to use third generation cephalosporin, which has the same gram-positive cover plus a gram-negative cover as well. So that is I think that's the reason as to why we are adapting to such a combination. And I don't, obviously, I don't know the trial evidence or any local statistics for that.
Thank you, Hirantha.
Yeah, and there's another question, what is happy hypoxia? That simply denotes the patients are happy in presence of a hypoxemic state. So they are not symptomatic rather, but if you do their oximetry, they would be hypoxic.
One more question about that, about pregnant mother, do we need to modify the treatment?
Not really. The guidelines are same as for a hospitalized COVID patient. Yeah.
Any other questions? If we can give 5 more minutes to conclude this session. If you have any questions, if you can ask now.
I am Dr. Kishan.
Yes,
Sir,
Krishan.
can you hear me?
Yes, Krishan, you can ask the question.
Sir, now from the OPD, we saw a lot of patients after hearing they have the COVID infection, they are psychologically depressed, and even the staff, our health staff, even start crying. So, are there any aspect in the psychology or getting from the psychiatric ward help? Are there any psychological support to this patient? Because if they depress, the immune status will go down. So, are there any a stage like that to give the support when they are in the ward, and they are telling, even they are calling us and telling they are now the oxygen level, they are increasing the level from 5 to 10 and 15. Are there on that aspect, are there any chances of improving, sir?
Yeah, I guess the question is related to the in-ward patients. Is it?
Yes, sir. Yes.
Yeah. Now, in a ward setting, if we detect any emotional distress or psychological manifestations or even a psychotic manifestation, we then and there refer the patient to the psychiatrist and get the expert opinion then and there. Am I right, or rather?
And our psychiatrist, Dr. Kamal Valgam, is also very much sort of
Supportive, yeah.
Yeah, supportive, and he is also highlighting us about the psychiatric manifestations as well, apart from this anxiety and depression. So yes, we have to get the opinion then and there.
Anuradha, can I disturb you?
Yes, Dr. Gapan, you
Damage,
can.
yeah. Actually, this is the thing. That's what I was just trying in the past. We need to change our ward settings because when you combine, if you keep together these bad patients and marginally ill patients and some are very stable together, I think it's going to happen because they are looking at the other one. So
Yes,
we need to
yes.
separate patients to give the separate psychological care, and we must minimize their disturbances as well. So we were trying that, but it's very difficult because we were not ready. We were not ready with the wards and all these things.
Yeah.
So when you have a patient around 80, 85 years old who is going to die, and unfortunately they have got the COVID. And are we going to do anything for these patients? Just we are giving the possible care and the support. But these people, those who are having young patients or those who are having very marginal illness, they have to look at those dying patients as well. Then I think that's what it happens in the wards. If we can separate them to a different places, you can get a better outcome.
Now we have actually 4 wards to manage this COVID patients. Ward A and B for critically ill patients, and C and E for not very much ill patients. So by that, we can sort of um, uh, control this bad exposure. But I don't think that is also the ideal. But I know I can understand, but with this limited resources, it sort of, if we try, we can achieve to some degree, but it's sort of not complete, I think. Anything, Hirantha, you?
Yeah, similar experience I have experienced as well. Patients dying inside the COVID wards, and the body is kept for a few hours, and sometimes the bystander is with the body throughout that period. So we should be rather taking all the steps to separate, rather to take away the body and try to separate the bystander. That is one aspect, actually, Dr. Gamage. Thanks for that. Thanks for reminding.
Yes, other thing, Hirantha,
Yeah.
so they can't meet their family members always. That is the thing, because
Yes. Yes.
there is
Yes.
no way.
Yeah.
Where I think still this you can see the ICU patients through the windows. At
Yeah.
least if they can communicate and they can see the patient or the relatives, the patient can see their relatives, that is better. That is
Yes.
better actually. But when we set up the ward again, we must think all these things as well.
Absolutely. Yeah.
Thank you, Hirantha. Thank you, Anuradha.
Okay.
There's another question.
Yeah.
Take this
Yeah.
question
Yeah.
as the last question. Do we need to tail off dexamethasone or can we stop abruptly?
Again, a good question. Now, this rather depends on the clinical severity of the disease. Now, if we see a severe disease pattern in radiological imaging and if imaging, then we rather can't stop dexamethasone abruptly. We are rather converting dexamethasone to another steroids like prednisolone or even a steroid sparing agent like MMF. Then we have to continue for some time, and after there's good clinical recovery as well as radiological resolution only, we are going to tail off the treatment. And for other patients who have got their x-rays cleared off and their symptoms cleared off, yes, we can stop dexamethasone abruptly for 10 days at day 10. There is trial evidence for that as well. In fact, in the recovery trial, they have given dexamethasone for uncomplicated patients for 10 days and stopped abruptly.
I think now the time is up. I want to thank Dr. Hirantha Pathirathne, the consultant respiratory physician, for his excellent presentation and enlightening us on the current trends in managing COVID pneumonia. And also, I want to thank everyone participants for their active contribution. Thank you very much. I think we all have learned a lot. Thank you very much, Hirantha.
Yeah, thank you, Ananda, for moderating, and thank you everyone for participating. And thanks again, UCS, for arranging this series of lecture. I hope the next 3 encounters will also be quite useful, and please do attend to those 3 lectures as well. Thank you.
Thank you very much.